Hello, everyone. We're going to be talking today about evaluation and management services, the auditing that you can actually do for E&M. So it's a little bit different. Most people think that when we audit, that that's all we're auditing is the E&M, but it's not. We're doing much more, as you've seen through all these previous lectures. But now we're going to dive down and talk about the E&M itself, because that is a major component. The fact is this is where most people find mistakes, is the E&M. So that's what gets talked about a lot. And with E&M, our learning objectives are going to be, we're going to talk about the CPT manual. Primarily is what we're dealing with E&M. The diagnosis codes are what validate the E&M services, right? So it does play a part, the diagnoses, but the E&M is the evaluation and management of the illness or the condition that the provider is taking care of the patient. We're going to look at the different types of E&M services, because it's more than just a doctor's visit, right? We have an ER visit, we have consultations, things like that. We're going to look at what CMS states about the guidelines, the documentation guidelines, and there's two. There's the 95 and the 97 E&M services, and how you're allowed to pick whichever one suits your purpose and needs for your entity, for your doctor's office. We're also going to talk about the key components that are required for determining the leveling of your E&M, and we're going to talk about medical necessity, and that's where that ICD-10 comes in, the not the diagnostic, but the diagnosis. You know, what determines something that is a 99213 versus a 99214, and then what makes a 99214 turn into a 99215. And a lot of times it has to do with the diagnosis, how many diagnoses and more, which we'll talk about. So the E&M codes are going to be in your CPT manual. E&M is at the beginning of your CPT manual. And when you look at the categories of the E&M, you're going to see that the very first area in E&M that is listed is for office and outpatient services. And what distinguishes the two of them, for office and outpatient, we have two areas. We need to know if they're a new patient or an established patient. We'll talk about that in a moment. Initial observation care, as well as subsequent observation care. So what makes an initial observation care different from a subsequent observation care? We're going to also talk about initial hospital care, and is there a new and established patient involved with that? Subsequent hospital care, observation or inpatient care services, and this is going to be your initial admission and the discharge. So when you're officially made an inpatient to the time that you're officially discharged from services, and how we are going to level that. So the first thing we're going to kind of look at as well is dividing up some of those other services. Those first ones we talked about are, you know, probably a big chunk of what we see as an auditor, but there's also consultations, and there are office, and then there's other outpatient consultations. Is a new or established patient a component of that? Well, we're going to talk about that. Inpatient consultations. So you have a patient that's put in the hospital, and then we realize that it's a heart condition, and we need to bring in a cardiologist to give a consult. Emergency department. And of course, a person can come into the ER and then be discharged from the ER. And there's leveling that's involved with that. It's not as intense as it is with other getting the levels for a doctor's visit. Then we have consultations with inpatient and outpatient. look at the top. We've got consultations, and it's office and other outpatient consultants, then inpatient consultations. But then we're going to talk about consultations for just inpatient and outpatient services. It's not meant to be redundant. Nursing facilities. So if you have, if you've ever had anybody, a loved one, in a nursing home or a skilled facility, this is going to be what we're looking at. When a patient comes in, that very first initial evaluation, then subsequent nursing facility care. So the doctor comes out and continues to follow up and treat. There's some other areas that get E&M services as well for nursing facilities. Domiciliary, I can never say this right, so I'll say domicile and rest home, meaning somebody staying there, but it doesn't have the level of skilled care that a nursing facility has, right? They still need somebody to come in and check on them, but they don't need somebody making sure 3 times a day that they've taken their medication, or coming in and you know, checking IVs and stuff like that. And home services. So there's a new patient, established patient in both of those. Some other E&M services that we need to pay attention to, because they're not based on the key components like everything else. They're a little bit different, is hospital discharge services. Doesn't have a leveling like outpatient visits for new and established patients. Emergency services that are classified under other. Critical care service, and that has a little area of its in and of itself. So when you look at your CPT manual and you open that up to the E&M, you'll see that the critical care services, sometimes that can get a little confusing, what's classified as critical care. So we're going to talk about that. Nursing facility discharge. Again, sometimes people are in a nursing facility temporarily. So maybe it's a elderly person that has fallen and fractured their hip, and they're not sick enough to be in the hospital anymore. They've had the repair to their hip, but their recovery still needs nursing staff, but not at the level that we need in a facility like a hospital. So it's kind of like a step down. And then when they get to the point where they can maneuver and ambulate on their own, and we make sure that there's not going to be any infection or any other problems, complications, they get to go home. As well as domicile, rest home, and home care plan oversight services. And that kind of falls into when we're getting into home health as well. We have prolonged services, and there's more than one type of prolonged services. Sometimes you have prolonged services where it's direct patient contact. Okay, so we're working with that patient. And then other times it's without direct patient contact. So we need to be able to determine which is which, right? And standby services, what happens if we have somebody that is going to have possibly have a C-section, and you know, things aren't going so well, we're not sure, but we have the surgeon stand by just in case we need to do a C-section. As well as case management services, things that this would fall into. Great example of an anticoagulant management when somebody's on Coumadin therapy, and medical team conferences. So let's say that we've got a patient that's getting ready for a heart transplant or a kidney transplant, and we need a team conference to go through the steps and make sure that this, you know, is it the right time to be doing this, and who are we prepared so that when a donor is available, we can just immediately go in and do the procedure, everything's set up and ready to go, because you never know when you're going to get an organ, right? Preventative medicine services. This falls under both new and established patient. And then there's counseling for risk factor reduction. We maybe are working with a particular patient because they've been diagnosed with COPD, and we're trying to help them stop smoking. so we may be looking at interventions for behavioral change. And non-face-to-face services like telephone services, which are really a big deal now, right? We see that so much more than we did in the past. It's always been around. I mean, it's been around for years because we have particular areas that maybe don't have a specialist and they call in, and then online medical evaluations, as well as interprofessional telephone and internet consultations. Now, you know what? This is phone services and non-physical face-to-face. I just went to a lecture where it was the prison system, and the prison system in Texas is absolutely amazing, and they've been doing these services via telephone for years, and they're pretty well a leader in this type of service and how well it works, because it's less dangerous to take that particular inmate, and as far as time consuming and the staff that's involved, taking them in to have them checked if they think that the patient might have pneumonia versus an upper respiratory infection. And so they can literally do the x-ray, they can do whatever the provider wants and do a consultation and see with the nurse and the patient, have them ask questions, and they're set up like a hospital right there to do everything, and being directed by the provider via webcam. So it was a great lecture, very fascinating. And that happens in these outlying places where we don't have providers. Maybe they're up in the middle of Alaska and they can't come in. So you have one provider that takes care of this whole town, but we need a consultation for a heart specialist, you know. So pretty fascinating. Evaluation and management services that are special, like basic life or disability evaluation services, or maybe we have work related or medical disability evaluation services. And that would, we could use my son, for example, that has epilepsy and autism. He is not on disability, but eventually at some stage in his life, he may be put on disability. And so it would be a special evaluation like this that he would go through. Newborn care services, delivery and birthing room, attendance and resuscitation services. And then we have inpatient neonatal intensive care, or NIC units, and pediatric NIC units. So they can do inpatient neonatal as well as initial and continuing intensive care services. This is a higher level of evaluation and management, right? Because if they're in the NICU, we know that something severe and critical has happened, or they won't be there. Care management services for chronic management, and as well as complex chronic care management services. And so we'll break down that and give you kind of a better explanation as to what that is. There's transitional care management. So we're moving one from transitional care, say from a nursing facility, to one that has nursing staff available if it's needed, but the person can take care of themselves, right? So what's that transitional care management? Advanced care planning, as well as we have an area for unlisted E&M. So out of all of this other stuff, if we don't have a category for the E&M to fall into, we've got other. And we understand with coding that other means that it's defined, we just don't have a code for it. We don't have an area to put it. The key components that we're dealing with when we start working with E&M is to know how this started, when the background. So back in '92, we had all the narrative and components kind of changed, and back then, it was more based on reimbursement on diagnoses. We're kind of shifting back towards that with risk adjustment, but the evaluation and management became a larger component back then. So the intensity of the service was actually starting to be measured, not what was wrong with the patient and how many diagnoses the patient had per se, but it was the evaluation and management of all of those diagnoses. And then we got that definitions. Are we, example, they do brief, intermediate. Those were, what's the difference between a brief exam and an intermediate exam, right? So that became more defined. And then these leveling with the CPT code set became very specific and allowed us to measure the intensity because we had a better definition of how to click off components, I guess would be a good way of saying that. So if we had an E&M service and it required documented key components, then we're going to have first a history. And what is looked at with the history? We have the chief complaint, we have the HPI, and then we need to review the systems, and we have the PFSH. And so past family and social history. We have a chief complaint, and that could be the patient is being seen for COPD. So that's going to help us. That's the first step in getting our level of service. Then we have the HPI. And so that's the description of what's wrong with the patient. And then we have the ROS, the review of systems. And that's where we're going to really take inventory on everything that's wrong with that patient. We have an examination. Now there's 4 levels for the examination in the CPT. We have problem focused, expanded problem focused, detailed, and comprehensive. Then we have our MDM, or medical decision making. This is something that ends up being probably less clear. There's a little more gray area. It's not as black and white. So we have to figure out what's the complexity, what's the medical decision making, and the complexity that follows the diagnosis. Remember when I told you that I used the example of our patient that came in with cerumen in his ears. He was complaining, if they say they're complaining of ear pain and not being able to hear, that is one level of the medical decision making. Okay, so person comes in and never had any problem like that. They clean the cerumen out of the ears and irrigate the ears bilaterally, and that's the end. And the medical decision making isn't going to be very high for that. Versus another person that came in with the same signs and symptoms, but they have hearing loss, some type of deafness already, and then they have the brain tumor. Right? Medical decision making changes. Now, they may just do the same thing, clean the cerumen out of the ear, and they're fine after they, do an evaluation. But the medical decision making for that patient is going to be a lot higher and more detailed than one that just has ears with a buildup of earwax, right? And no other conditions. There's actually 4 types of medical decision making. We have straightforward, low complexity, moderate complexity, and high complexity. Now, we have to look at contributing factors. And one of those contributing factors would be counseling. What type of counseling can be done? The first one we think of is the most common, counseling with the patient. So we're talking to the patient. He's recently diagnosed with COPD. He's a smoker. And now the provider says, you know what? I know you've been struggling to stop smoking, but the time has come where we've got to be really aggressive now, and we've got to stop, or you're going to turn into an emphysema patient, and we can't. You get worse from that point. So let's do counseling about what we need to do to be aggressive about stop smoking, and then it may also be an evaluation with the family. In addition, the diagnostic results impressions and recommendations could all be talked about. The diagnostic results of now you've been diagnosed with COPD, and let's talk about how that changes your life. What recommendations I have for you. We're going to have you start seeing a pulmonary specialist. The prognosis. Okay, people live with COPD. You know, there's medications that are very helpful, but your prognosis is going to be worse if we can't, you know, help you stop smoking. That's going to change your prognosis drastically. Talk about the risk and benefits of the management options. So this is how we can manage this. We can, you know, change the medication that you're on. We need to be careful with your diet and exercise, because if you gain weight, it's going to be difficult on your lungs, as well as let's talk about getting you in with a pulmonary specialist and starting that care management options. The instructions for the management, you know, this is the new medication that's been very effective to treat COPD, and we're going to put you on that, and then I'm going to have you come in a month, and we're going to follow up, and we're going to see if that is making you feel better. Are you getting relief? Risk factor reduction, like we're going to get you to stop smoking. Patient and or family education. If there's anybody else in the family that smokes, it's not just the patient that needs to stop smoking, but everybody that they're in contact, because we know secondhand smoke is going to be a problem for this patient. And as a family, everybody's got to work together. The importance of compliance and treatment options. All of this falls under counseling. We have a coordination of care. So let's take that same patient and say, you know what, I'm going to have you go and do a consult with, you know, Dr. Breather, I don't know, think of some name, you know, and then this particular doctor is a pulmonary specialist. I want her to evaluate you and see a little more in depth as to where you're at. And then if she feels that she needs to take over your care, then I'm going to switch that COPD diagnosis under her, and she's going to follow your care after that. So we're going to coordinate care between, you know, I'm your GP and I can treat and take care of you, but we may need to get the specialist to come in and help us on your care. Also, nature of presenting problem. This is stated via the CPT manual, so I'll read this. A presenting problem is the disease, condition, illness, injury, symptoms, sign, finding, complaint, and or other reasons for an encounter, with or without a diagnosis being established at the time of the encounter. So our person's really having a lot of trouble breathing. They are a smoker, but they've been trying to quit, so they went down to a pack a day to just a couple cigarettes a day, but it, you know, they know something's wrong, and then whether you give them the diagnosis of COPD or not, it still is the presenting problem. Time is a major component of this. There's two types. We have face-to-face time and we have non-face-to-face time. So what is established as face-to-face time? It's going to be defined as the physician or other provider spends actual face-to-face time with the patient or family. Then we have non-face-to-face time, which is not included in the time component. And then we have a hospital setting that's unit or floor time. And so that's a little bit different. And Boyd, I need to take a break real quick. Can I pause for a second? Give me 5 minutes. Are you there?
You bet. Go ahead.
Okay.
Check 1, 2. Check. Check 1, 2. Ready?
Yep. Okay. Hold on. Can they hear me?
No.
I thought I was going to throw up. I don't know what happened.
You know?
I'm good now. I don't know what it was. Okay, hold on. Okay. Do I need to do anything on my end?
No, I'll just give you a 3, 2, 1 again. Okay.
Okay.
Ready?
Mm-hmm.
In 3, 2.
Instructions for selecting a level of E&M service. Now, this is the main focus of what we do in evaluation and management. This is where the confusion ends up being. Once you get it, you don't ever lose it, okay? But that there is a fine line between going from a I'm going to use the codes, for example, the 99213 to a 99214 for an established patient. And we get nervous about it because we think, oh, if we do a 214, we might, be overcoding, or a 213, could possibly be undercoding. So understanding how it works is, and also there's a little bit of opinion in there sometimes, but going through the instructions on how to level, the more you do it, the better you get at it. And so let's go through that now. The first thing we need to know is the history. Now that's probably, in my opinion, the easiest component to look at is the history. So you've got personal, family, and social history, 3 things that you look at, and it's usually pretty blatant, right? Family history, the patient's mother died of breast cancer, and the patient's father is alive and healthy with no chronic conditions. And then social history, the patient works full-time and is married with 2 kids. And so you've got the past history is the patient had a cholecystectomy 2 years ago, right? Now, we also need to talk about the exam. This is where I think some people get confused, but it's really just, if you have an audit tool in front of you, it's just literally clicking off body systems. And then the complexity of medical decision making, that can also have a lot of gray in it, right? So, you know, well, the provider wrote a script, so right there it's a 99214. Yeah, but was the script for Debrox over the counter because their ears had cerumen in it? No, that's not a 99214, especially if nothing else is wrong with the patient. Now, if the patient was given a antibiotic because they have an ongoing UTI that hasn't been resolved, and the patient's going to be put on a specific antibiotic that they're going to take for a month at a time, to see if we can, you know, get rid of whatever that bacteria is, and medical decision making may be higher because they say, you know, we can't get this taken care of. I'm going to refer you over for a consultation with a urologist. You know, that's higher medical decision making with one prescription, right? So if we need to select the E&M services, we're going to look at all of the key components. So we're going to look at the history, the exam, and the medical decision making. And the key with that is that we need to meet or exceed. And now you've probably heard that again and again, right? And I'm going to kind of assume here that if you're doing an auditing course, you have already been a coder for a while, and so this is an area that you know can have it's very specific, but determining whether it is a medical decision making that's higher or lower is gray. But once you've determined that, it's either going to meet or exceed, and that is not difficult to determine. The all of these following areas is going to fall under the requirements needed for E&M to meet or exceed. And I'm not going to read those because they're listed for you. If we have a patient that has to have all three components at a specific level, not meet or exceed, but we have to have all three components, that's going to be an established patient, right? And other areas where it has to be very specific would be things like subsequent hospital care. Now, let me retract that. Meet or exceed is going to follow for two of the three components is going to be established patients, subsequent hospital care, etc. New patients, you're going to have to meet all three components, but these are the ones that you have to meet or exceed two of the three components. So the exam and the medical decision making, you have to at least meet it or exceed it. And the history can be lower because you only need two to get to that level, right? And then for things like new patients, it would be three of the three. The CMS is, they've revised the documentation requirements and the guidelines, but for the most part, it's been the same over a very long time. And you know, once you got it, like I said before. However, AMA and the CPT-I guidelines, they differ from what CMS requires for Medicare, right? But we code off of the AMA CPT-I guidelines, especially when we're auditing. The documentation is going to have pertinent facts, the findings, the observation, everything that we need will be in that record. If it's not written, it's not done, correct? So that is just like a mantra, right, for auditing and CDI people. But again, it's got to be notated. So if you have a past illness, that maybe the patient has had pneumonia twice before that year. Wow, that's really pertinent. You know, that's not normal. And so that would be part of the documentation if the patient is coming in and they have diabetes or they have a new diagnosis of COPD, right? Now, the payer, then what they want is they have a contractual obligation to their people that are enrolled to require a specific amount of documentation for coverage. And for the most part, that is right there with the guidelines. However, they may have certain things that they require or they want you to do that another payer may not. Like Medicare may require this, but Blue Cross Blue Shield of Texas is not going to require that. But everything still has to be consistent. The principles of the medical record documentation is that, now we've talked about this before, have to be complete and they have to be legible. And we don't just mean legible as in the handwriting, right? Because we have less and less of that. But it has to be even if it's a copy of a copy of a copy, it starts to fade, right? It has to be something that isn't bent or twisted or folded over if it's being scanned in. It has to be legible. It also has to have a few components. We have to know what's the reason the patient's being seen. Are they being seen not for follow-up as the chief complaint, because that's not enough information. We need to know what they're in follow-up for. They're in follow-up for their COPD change of medication to make sure that it's still working, right? They're in follow-up for evaluation of the past 2 weeks blood sugars that they've taken at home. They're in follow-up for a visit to see how their stump is reacting after they've had a BKA to see if they're ready, it's healed enough for starting a prosthetic, use of a prosthetic, things like that. And in that, it has to be relevant to the other components, the history, the physical exam, and any diagnostic tests that are being done in the medical decision making. We need an assessment, which is the clinical impression, but we see a lot of times now they say assessment, but in the past we should say, what's the diagnosis, right? What's the diagnosis? So if we're talking about our BKA patient, is the diagnosis that, or the impression that the person's stump is now healed enough that they can be sent over to be fitted for a prosthetic and start that process, and then we'll be doing physical therapy to learn how to walk with a prosthetic, right? That would be the plan of care. And then everything has to be date and as well as everybody involved has to be identified. Legible identity of the observer is how they say that. So we need to know the date of service, and we need to know all the person's demographics in there. What's not documented, if it's not documented, for example, rationale for ordering a diagnostic. So why are you going to go in and do another x-ray of this patient's stump after a BKA, and it's been, 8 months? Why are you doing another x-ray? Because the patient is having pain on one quadrant or one corner of that stump. And we need to see if it has to do with something about a bone spur or the way that the bone, was cut, or is it something vascular? Is it something part of the nerve tissue? So we're going to go send out and do an x-ray and just see if that is going to be part. Or maybe we're doing a diagnostic test because the patient's blood sugars have been off. So we're going to, and they're diabetic, and we want to go do an HGA1C. Did I say that wrong? Anyway, we want to see what they've been averaging for the last 3 months to see, is it something just really relatively new, or they've been off for a while and they're just noticing that. As well as, is there any ancillary services that need to be done? Again, if our patient is ready to be fitted for his prosthetic, ancillary services, then maybe we need to make sure they get into a support group with people that have prosthetics so that they have somebody to talk to, or getting ready to start doing PT for a prosthetic. It's one thing to have PT when you're an amputee, but it's another type or it's another avenue in that PT when now you're going to start walking with a prosthetic. If there's any past or present diagnoses that need to be evaluated or have a consultation come in, maybe there's a risk factor involved. Let's say that our patient that is that has had the BKA, let's say it was a traumatic BKA, you know, let's say they were in a motorcycle accident and lost their leg. However, they're diabetic. Now, most of the time when they're diabetic, we just assume that the BKA is due to their diabetes, but a traumatic BKA is different. So, but that changes the thought process and all of this ancillary services, because we know that diabetics don't heal as well, and they're prone to getting ulcers, right? So that's got to be evaluated when we start fitting them for a prosthetic, right? Because that is a pressure point now that we've just created. Maybe the patient's progress or responses to treatment, or maybe we need to revive a diagnosis. In doing that, we're going to be looking at both the CPT and the ICD codes, and the insurance, the payers are going to be looking at those codes. They'll all be on the billing statement, and they're going to support the medical record. We need to make sure it's all supporting. The MDM, the medical decision making, has to match the CPT, the procedures. So there is this crucial partnership between ICD and CPT. What makes more services necessary for this guy that's getting a that's had a BKA that is getting ready to be fitted for his prosthetic? And because they're both of these patients have the same type of BKA that was done, and they both have traumatic amputations. Well, one's a diabetic and one's not. One's older than the other one, right? That's going to be definitely pertinent. If we have diagnosis codes that we need to identify the medical necessity services, we need to make sure that we describe the circumstances and the conditions in the documentation. And you as the auditor is going to make sure that that is part of that component. This is where you see a little bit of lacking from time to time in the documentation. And as the auditor, you have to put all these pieces together and say, you know, I understand that you're having all these other procedures done and ordering all these other tests, but why? You know, because you normally treat people with amputation. Why is this patient different? Oh, because they're diabetic, right? And they've already, and they also have some inner ear problems, and so they're a fall risk more so than, and this person lives alone or whatever. It has to be documented in there. As well as you have to see when a claim is being filed that you have the appropriate CPT and the ICD codes together, that one doesn't stand alone and give a description in and of itself. It has to be a team between the two, right? Why is this a higher evaluation than this other guy over here that has the same, you know, appears to be the same circumstances? It's not the same circumstances. This particular person is a traumatic amputation, and this one is a medical amputation. Right. We're going to apply the following principles whenever we're trying to look at medical necessity. And like I said, this is this gray area that we have. What is the principal diagnosis? Okay, so let's say our principal diagnosis is a BKA, traumatic BKA. What's the condition? The patient is 8 months out and they're going to start looking at prosthetic. What's the problem? The problem is this patient's diabetic. Other reasons for medical services and procedures, the patient also has an Meniere's disease, which makes them dizzy. And so therefore we, all of those are contributing factors that give us medical necessity to have additional services and tests being done. And we're going to then code to the highest level of specificity. So this particular person, even though you have two people that have had a BKA and you're running those scenarios, patient B, that is the one I just described, versus this 30-year-old overall healthy, a very athletic person that had a traumatic BKA due to a motorcycle accident. They both had a motorcycle accident. Their medical decision making isn't going to be as high as patient B. Patient A, pretty straightforward unless they come up with any complications. But this guy over here, we have the possibility for a lot of complications that exist. Never use rule out statements when we're working because they are that is not the type of diagnosis that we want to see for either office or outpatient services. You can't code off of a rule out. So what are we ruling out? Diabetes? No, the person has a specific diagnosis, elevated blood sugars. Right? We're not ruling out diabetes, which may be what the thought process is, but we can't code rule out diabetes. What do we code? We can't code diabetes. No, we have elevated blood sugars, right? Why are we trying to rule out diabetes? We have to have that definition. And so when you are looking at things like rule out, and the provider can write rule out diabetes, but what's the diagnosis? Why is he ruling out diabetes? Because we have elevated blood sugars and these signs and symptoms. So in the outpatient world, that's what we're going to actually code for. We need to make sure that we're very, very specific when we are documenting the patient's condition, illness, or disease. Now, when I say we're doing that, I'm meaning that when your provider is doing that and you're reading it, and again, you're giving a opinion to that provider, right? So that's what we want to see in the documentation when we're auditing. We need to distinguish between things being acute and chronic because there's different codes, and we can have acute on chronic, right? We also want to make sure that we identify anytime we have an acute condition that is an emergency. So the patient's having chest pain, but then it turns into an acute MI, right? That's an emergency situation. We want to make sure if we have chronic complaints or there's secondary diagnoses that we only are coding them when they are being treated. Now, remember I told you about how I would love to see an EMR set up where it has a list of chronic conditions? That is not meaning that those are being treated for that encounter. No, that means that they're being identified as chronic conditions that have been validated by the provider, but that's not why the patient's being seen that day. And this all plays a part in establishing our medical decision-making. We also want to make sure that in the documentation, we find out if there's an injury, how it occurred. Why? Because how are we going to determine that this was a traumatic BKA versus one due to a diabetic ulcer that got worse and ended up causing gangrene? Right. So we need to identify what was the injury and how it occurred. And that's going to establish the medical decision-making. Medical decision-making for a diabetic may be higher than our patient that had a traumatic BKA and overall healthy otherwise. Documentation has to show that for us. We made sure that the patient's record has all of the information that is needed for the payer. Not just the payer, but that, the payer is a lot of times what we're focused on. Just good documentation overall carries all of these components that we're talking about. But for the E&M, predominantly we're focused on what does the payer want. We need to make sure that we're giving all of the information to the payer so that we are being reimbursed, our providers being reimbursed for the work that they're doing. Right? It's not that we want more money for the work they're doing. No, we want the money for the work that they're providing. CMS has a comprehensive error rate testing program. Why? Because they're the Medicare is the largest payer, and so we not only do they want to make sure that there's not fraud and abuse being done, but we also want to make sure that it's we're educating our providers to show them what the payer needs for proper documentation to be able to get to the highest specificity. And so it's not just them coming down and being, you know, like Big Brother looking over your shoulder. There's a component of let us educate you so that we can communicate and make sure that you're being reimbursed for the services that you're providing, and mistakes aren't being made, and that we're overpaying or underpaying you. So the data that's gathered by CMS, they will they have determined that 45% of services are incorrectly coded. 37% of services reported contain insufficient documentation, and that documentation for 5% of the services reported was not provided. And 11% of the services reported contained errors relating to diagnoses, codes, as well as improper modifier use, lack of sufficient documentation for procedures in the office. Now, that when we pull back and look at that, that is, you as an auditor play a huge part in making sure that these statistics get better, because you're going to be auditing, finding errors, and then educating on how to improve these errors. So CMS has done the work and said, okay, these are the problems that we're seeing. You know, 47% was incorrectly coded. Wow, you know, and then we're talking about it, then we get down to the errors related to the diagnosis codes was 11%. You know, so what does that mean? We need to educate our providers on the documentation. We need to make sure that we've got coders who are certified and skilled in particular areas that are, you know, billing for these services. And then on top of that, we need billers that know how to follow up for modifier usage, right? So those statistics are pretty high. Now we're going to talk about the different types of E&M service guidelines that we can use. They are 1995 versus 1997. So we say 95 or 97, of course. And we need to know as auditors both the 95 and the 97 E&M documentation guidelines, because the provider is allowed to pick which one, 95 or 97, works best for them, for their services. So what a GP uses over here that has a relatively small practice versus a podiatrist is going to probably be two different ones, because one is really works well with specialty groups and the other one is much more broad, right? So you as the auditor have to understand which one works better, because you will educate the provider and the coder as to, you know, hey, I've noticed that you're using the 95 guidelines in your audit tool, but you know, did you realize that 97 is probably going to allow you to have more reimbursement because of the specialty work that you're doing, and we want to make sure you're being reimbursed properly. And again, it really depends on specialty, ultimately making these decisions. And you as the auditor is the expert in this. So some specialties could use either one, reporting the E&M services. And again, this is only dealing with E&M. The first key components of what CMS requires for their E&M is history. So if we got to look at the history contains these elements. We need the chief complaint, okay? And that's going to be for every level. We have to have that. We have to have the H&P, the HPI. So what's the history of the present illness? When did it start? Review of systems and the PFSH. We got to have that. Now, not every one of these elements have to be documented for every patient encounter. Because again, how relevant is the PFSH on a person that's just coming in because they have cerumen in their ears to be cleaned out, right? It's a lot different than if you have a person that's having coming in because they have shortness of breath and chest pain, and atherosclerotic heart disease runs in their family on both sides, the mother and the father. Big difference, right? And the extent of the information is for the history is really going to be the provider's determination, right? So as an auditor, you can't come in and say, well, you realize you could have taken a much fuller history on this particular patient. No, it's up to the discretion of the provider. We make sure that everything is documented properly, but we don't tell the provider, you know, to what extent the documentation has to be done. Now we can give suggestions, but our job is not the medical decision making. Okay. Ours is to educate on what is entailed in medical decision making that would determine the code, right? The second component is going to be the exam. So this is going to be a lot of times the part that's written out or dictated into a progress note. Then we have to make sure that there's no evidence of examination during, if there is no evidence of examination during the encounter, then that's a problem. Every single encounter should have some type of an exam, right? Last, we have the MDM, the medical decision making. So what's the presenting problem? What's the amount or complexity of the data? And what's the risk? So the presenting problem is that we have a patient that is getting ready to see if, in follow-up, to see if they're ready for a prosthetic. The amount and complexity of the data reviewed is that, you know, we're going to look at the healing process. We're going to review the past visits that they had. We're going to examine the stump and make sure that everything's healed properly. We're going to talk to the patient about you know, how the stump has been feeling, if they're having tenderness or pain, et cetera, et cetera. The complexity also about, is there any other comorbidities like the patient being diabetic, and we're going to do counseling on what that means when you start putting pressure on that stump. And then the risk, okay, you're diabetic, so you can't be on that prosthetic as long starting out as somebody that doesn't have diabetes, because this is a new pressure point for you. And you probably don't have the sensation in the nerve endings to the extent, because you're diabetic and because this is a BKA, you know, that is going to give you a heads up and a warning. So the risk is that we, you know, need to make sure that we don't end up with an ulcer and then end up having to take more of your leg, right? So much more complexity. Well, we're going to also talk about consultation, because that is a type of visit that gets an E&M service. And the difference between, or what constitutes a consultation, this can be confusing. A consultation is actually a request by one provider to get an evaluation in E&M by another provider or a source. Okay, that is a consultation. And then in return, they expect to get a recommendation. And then if it determines that that patient is going to, is that provider that you got the consultation, are they going to accept responsibility for the ongoing management of that patient? Okay. And then whenever you have consultations that are outpatient, your code range is going to be 99241 through 99245. But if it's an inpatient consultation, it's going to be 99251 through 99255. Okay. So just know that whenever you have a consultation like that, you are going to report that separately with any identifiable procedures or services and stuff versus an initial encounter consultation. So again, a consultation is requested, and then in that consultation, they determine, I'm going to now get a consultation with an endocrinologist because I've seen that your blood sugars have been up. We've been thinking that you're diabetic, but something just doesn't seem right. And so I think instead of my looking at your record and following your care, I'd like to get an opinion of an endocrinologist and see what they say. And if they say, yes, this is just basic type 2 diabetes and nothing, they don't feel like anything else is going on, then you're going to come back to me and I'm going to follow this diabetes. But if they notice something is not typical and we need to have you start seeing this endocrinologist, then again, they may accept responsibility for your care. Me as your GP, I'm going to take care of everything else, and I'm going to coordinate with the endocrinologist if they take over your care. So what's the difference between a consultation and a referral, right? So a referral is that transfer of total or specific care. So again, I'm your GP. I'll be taking care of you like I have been for the last 5 years. However, this is something that I think would be beneficial if the endocrinologist follows this endocrine disorder that you have. And because they're the specialty, they're going to be able to give you more information and follow your care, and they know the latest of everything that's happening that I don't. But we'll coordinate together, but they're going to take over that. They're going to refer for just your endocrine disorder. So there's a checklist that we need to think about whenever we're going to be using codes 99251 through 99255 for consultations. They're called the 3 R's, and you should probably write these down. We need a request of an opinion. So I'm going to send you over to the endocrinologist and we're going to request his opinion. And then we're going to get a rendered opinion or service. This is what the endocrinologist suggests, that we do these additional tests, and then they're going to be a report. And that's really going to give us an idea of where we need to go forward. Do we need to refer to have the endocrinologist take care of you for this, or am I able to handle this as a GP? Because I know your care and I know your situation better, and it's something that it's not what we were suspecting it was going to be. The endocrinologist verified that. So I think you can stick with me to manage this, and then if we need to get a second opinion by him later, then we can absolutely do that, right? When CMS made a determination back in 2010 that consultations were not going to be covered on Medicare anymore. And again, it's been a while now since that's been going on, but that was a pain point for a lot of individuals. So again, Medicare doesn't pay for consultations. Now, other payers pay for consultation, but the fact is whatever Medicare does, everybody else tends to kind of follow suit, don't they? Right? Because they're the largest payer, and not, again, all of them have quit paying for consultations. What we need to know before we review a consultation is that the auditor is going to check what payer. is involved because there are CMS guidelines that are followed, right, for CPT consultations. CMS, what do they want? Even though they don't pay for consultations, they are reported. So when you're going to report a consultation, the things that you need to remember, each carrier is going to determine if it is a consultation needs to be reported, and then they're going to look at initial hospital visits, nursing home visits, maybe when they've had a consult requested, as well as outpatient office visits. There's guidance for reporting those. And the documentation needs to support the level of service. We have to show medical necessity, of course. And sometimes there's telehealth services. If that is a telehealth service that's being provided, then we need to know that before we report, because there are new G codes out there for telehealth consultations. That has been something that is more prevalent than ever before. Each year we see more telehealth being done. What happens if we have an emergency room visit and that code for consults 99281 through 99288? We don't have a lot that we have to pick from, but the physician billing for the ER services for the patient could be the patient's first personal physician in the emergency department, or it could be the emergency department physician. It's really based on what the patient's, the advice of the patient's provider. And they're going to determine if the patient goes to the ER or if they can go home, right? So who is going to end up being billed when you have a scenario like that? And then let's talk about nursing visit codes, 99211. What is a nursing visit code? That's the lowest level of E&M. And this would be in the outpatient for E&M management is still being done by the provider, but the provider doesn't have to do anything. The provider doesn't have to be there. Okay, so let's say the patient comes in to have a flu shot. That could be a 99211. The provider doesn't have to give the injection. And what's the established criteria for a 99211? It has to be an established patient, right? The provider-patient encounter has to be face-to-face, and the service has to be separate from other services performed that day, right? Or otherwise it can't be a 99211. Preventative medicine. Preventative medicine is unique in that it is seeing the provider with the absence of complaint or symptoms. So I'm coming in to see the provider because I think that I have a new problem, okay? But we don't, or we want to make sure we don't have problems with our colon, right? So you're going to come in and they're going to look at the scenario and say, yeah, you need to go have a colonoscopy, a preventative medicine services. That is going to be based on a reduction, a risk factor reduction against further diseases. That's the two things we have to think about. We don't want the patient to end up with colon cancer, and so there's nothing wrong with the patient, but their family member had colon cancer, so they don't have any complaints or symptoms, but we need to make sure that that's not going to be a problem. 50% of commercial insurance companies have some type of coverage for preventative services, and Medicare is doing it more and more. Why? Because it's cheaper in the long run to find out that a person has colon cancer very early than it is by the time they have signs and symptoms and complications. You go in and then you see that they have colon cancer, because colon cancer is easily treated, right? Same thing with breast cancer. We want to catch breast cancer early and do treatment before it gets into the lymph nodes and then goes throughout the metastasizes throughout the body. Same thing with colon cancer. So preventative medicine services are going to be coded at 99381 through 99429, and they're can be used for infant, children, adolescents, and adults, and they're based on if it's a new or established patient and the patient's age, because preventative medicine for a child is going to be different than preventative medicine for an adult. Back in 2011, CMS covers preventative medicines through the ACA, and they do initial annual wellness visits. It's called the IPPE, Initial Preventative Physician Exam, and it's reported with a HCPCS code G0438. Medicare only pays for one IPPE per beneficiary per lifetime. And usually you, well, they say you must get that first visit within the first 12 months of Medicare coverage. When we do observation care with E&M services in the hospital, it's divided up. Is it the initial observation care, 99218 through 99220? If it's reported when the patient is first designated in observation status, right? Then subsequent observation care is going to be 99224 through 99226, and it's going to be any subsequent management of that patient while they're in observation status. Okay, now if they're in observation status, the hospital has guidelines and protocol that deals with that kind of on an individual basis. Discharge services is going to be divided up into three categories. So there's different codes ranges for them. So we have hospital discharge services, going to be 99238 through 99239. Okay, you're in the hospital, inpatient status, and now we're discharging you. If you're in a nursing facility and we discharge you, then it's a 99315 through 99316. But if you're observation care discharge, you haven't been put in inpatient, it is a 99217. Very easy to determine, right? What happens when we have prolonged physician services with a patient? Now, these have to be face-to-face. We just have a few codes, the 99354 through 99357. They're used whenever the provider is giving prolonged services, and it can be above and beyond the usual services for either inpatient or outpatient. Now, this service is going to be used in addition to the E&M services at any level. Okay, so we're adding this on top of your other E&M codes, prolonged services. We have case management services. So this is where, we need to coordinate care. We may be managing healthcare services, initiating supportive services. Maybe the practitioner is responsible for the direct care of the patient, but we're doing a team effort here. So those can be the medical team conferences or what we mentioned earlier, like an anticoagulation management service that the patient is having done. And if you didn't know anticoagulation, they're going in and having PTI on ours doing often, and they could be telling them Monday, Wednesday, and Friday you're taking 5 milligrams of Coumadin, but on Tuesdays and Thursdays we want you to take 2.5, and then we want you to come back in on Friday so we can check your level again. Things like that. And then the next week they say, no, we're dropping you down to 2 milligrams Monday through Friday, and come back in Friday and we're going to check you again. And then then they call you up and say, okay, now we're going to have you do, and so that is, they have anticoagulation clinics. We used to call them Coumadin clinics. And that's all they did, is manage a person's Coumadin. Physician standby services, we mentioned this earlier, 99360. The example I gave you was the provider, the surgeon is on standby because there's a possibility that the patient's a VBAC and we may have to have a cesarean section. They're showing complications possibly, and we want to try to deliver vaginally, but things may trip into needing to do a C-section. So the provider is on standby, and then once the baby's delivered, their standby is over. Or nope, they're called in. They got to be ready. They can't be out playing golf. They got to be ready. They're on standby. So again, this is a type of prolonged physician attendance that's requested by another physician. Care plan oversight, we have just a few codes again, 99374 to 99380. That's separately reported and is based on 30-day intervals on a calendar, 30-day calendar period of time. And so you're on a, say, home health agency, or you're in the equivalent like that, maybe a nursing facility or hospice, and the provider is doing that oversight, and every 30 days they're doing another evaluation. When the critical care services are done in inpatient critical care, and this can be infants 29 days through 24 months of age, then we're going to do 99471 through 99476. These are reported per day. And what makes you pick one code versus another is that you have an initial patient encounter, and then we have subsequent encounters, and they're based again on the patient's age. Now, if we're doing neonatal care, then what we're doing is reported 99468 and then 99469, or reported for patients 28 days of age or younger. So again, age is very, very critical. And it's often very important on patients that are you're doing E&Ms on. With the critical care, we need to make sure that the documentation is showing that it is reliable and consistent delivery of critical care. So we need to show medical necessity, and we need to make sure it meets the criteria in the CPT. Critical care is cases that are not billed as emergency, and constant attendance or constant attention are prerequisites for critical care codes. So that has to be documented, or we can't use a critical care code. When we're dealing with inpatient neonatal ICU services or pediatric, we're going to be using 99468 and 99469. That's going to show that the physician is directing the care, inpatient care of a critically ill neonate, and the neonate is defined 28 days of age or younger. Okay, now this is going to be based on the date of admission, which would be 99468, and all the subsequent care for that is going to be 99469, and you can only report them once a day per patient. And so this is going to be codes that are used, usually when you have a neonate, they're in for a long time, right? So this is going to be a code that's going to be used frequently. They are not time-based codes, but they are purported per day. And then that also means that you need to know each individual facility will be based on days, right? The date, when the day starts and ends, is determined by the entity itself. And so one may be different than another, but for the most part, there's a standard. When we are doing pediatric critical care, the codes that we're going to be using is 99471 and 99472. Same thing as before, but the age of the patient is different. So this is going to be an infant or young child. So it's going to be now from 29 days to 24 months of age. So up to 2 years old. And again, it's the same thing. We have the initial code of 99471 and then per day 99472. If we do care management services, we have to follow these guidelines. We have establishing the care plan. We have to implement the care plan. We have to be there to revise the care plan, and we have to monitor the care plan. So those are all the elements that are going to be classified under care management services. If we are doing chronic care management, you have one code, 99490, that is used for that patient. Now, this is a lot of done with behavioral health. So this could be just medical, or it could be psychosocial needs of the patient. Complex chronic care management is going to need to have multiple illnesses. It's going to be multiple medication uses. It's going to be inability to perform the activities of daily living on their own. And they require a caregiver or somebody to administer, say, medications and care for the patient. Or it could be even managing the emergency department visits. Then we have regular care management services, 99490. This can be used with chronic care management. At least 20 minutes of clinical staff time is directed by a physician or other qualified healthcare professional, so it could be a nurse practitioner, per calendar month, and with the following requirements. So multiple chronic conditions, and at least 12 months or until death of the patient. So that could be hospice, right? Chronic conditions place the patient in significant risk of death. Again, we're thinking hospice. Acute exacerbation or decompensation of or functional decline is occurring. We have a comprehensive care plan established, and we're implementing and revising and monitoring the patient through that care plan. So again, we're ultimately hospice is where you're going to see that code used a lot. Transitional care management, a little bit different. We're going to have 99495 or 99496. So this is going to be based on complexity again, and what is the descriptors for the two different codes. It's going to be 99495 is going to require the face-to-face within the patient within 14 calendar days of discharge. And they're going to be along with moderate complexity medical decision making. So time is of the essence here, right? So if it's done on day 15, you don't get to use that code. Okay. Now 99496 is high complexity medical decision making face-to-face within 7 calendar days, right? Again, dates, very, very important. Dates and age with these. Incident 2 services. Now, it's important that you understand Incident 2 because, unfortunately, some providers think that it's an Incident 2 and it's not. These are services or supplies that are furnished as an integral, although incidental, part of the personal professional services that the provider is giving. It could be the course of a diagnosis or treatment of an injury or illness. Now, each state has different laws. So if you're in Texas, then it could have a different Incident 2 versus what is going to be in Florida or California or Maine or Colorado. So each state could say a non-physician practitioner. The auditor is going to need to check what that state's regulations are and be aware of it, and make sure that everything that is required for Incident to services is in compliance with that state. And then you need to educate everybody in the office as to what constitutes an incident to for that state. Maybe you have a coder that went from one state to another, and they're not thinking about it being a state difference, right? So when you bill for incident to with a physician's office, you have a supervising physician has to be in the office. Okay, the supervising physician whose national or NPI number is submitted to the claim must be immediately available in the office to render assistance if needed. The services do not require the supervision of the provider, so they don't have to be in the room, but the ordering physician does not need to be supervising the doesn't need to be the supervising physician. So the physician that ordered it doesn't have to be there. It can be another provider. Group practices are often ones that fall under this, and they can be a physician in the group can provide the supervision. The physician has to personally treat the patient on the patient's first visit. Okay, so they identify the problem, then it's an established patient, and maybe they have a worsening problem, and they initiate a plan of care. So then they have subsequent visits, and the NPP may build the incident to. Okay, now if you've got the NPP can treat an established patient with a new medical condition, and or the condition that's worsening or is being exacerbated within the scope of their practice. So if you are a nurse practitioner for a neurology, and that's what you're seeing, the patient is a neurology patient, yeah, you're okay. But if you're an OBG nurse practitioner, you're not going to be seeing you're not going to be treating a neurology condition patient. But they bill using their own NPI. Okay, so the documentation needs to show who did the direct supervision, and that all of this criteria is being met based on the law, the state law that you're in. Split share rules for E&M services. So when you have your provider is going to do an E&M service, and it can be in the office or the clinic, and they it's going to be reported under their NPI. If you have a split shared encounter between a physician and a non-physician practitioner, that's considered performed as an incident to. So then the incident to criteria is met, and the patient is an established patient. You can do that. If CMS implemented a new condition for incident to services, so that has been a problem with fraud and abuse, and Medicare providers who relies on reimbursement for these types of services are ones that need to have an auditor come in and look and make sure that all the criteria is being met. So CMS does allow providers to bill for the services by non-physicians for incident to for professional services of the physician. So it can be done. So now we're going to look at hospital, inpatient, outpatient, and emergency department settings. The guidelines that fall under these have face-to-face visits that are being for an E&M, and both the physician and the nurse practitioner is going to document and sign their portion of the visit. Okay, and then if there's no face-to-face encounter between the patient and the physician, then only the nurse practitioner's NPI is going to be used. Okay, so that's your contingency. You know, which one is going to be billing the NPI, and that's it, guys. So the next few lectures will be divided upon specifics, like you know, auditing a specific record type, and you're getting close to the end. So if you have any questions, don't forget to ask them in the club. Just double checking that we don't, oh, we do have some questions I see here, so let's address those. Mary says, oh, thank you for the kind words. And then let's see, Michelle says CMS has a comprehensive error rates just for physician's office. Nope, they have them for everything. Yeah, and you just have to go and look. You can look at you can go to cms.org and look at comprehensive error rate and put in what entity you want to see what it is. Can facility emergency rooms use either 95 or 96 as well? Well, no, I think, gosh, off the top of my head, I'm trying to remember which one. There's only, it's not the same. No, there's only a couple, there's only a handful of codes that they use, so they don't do the same type of leveling. And then Ermi said, confused with code 99591 of critical care. You know what? We have done some specific training on the 99591. And if you want, I would check out on the YouTube, our YouTube videos. And why don't you just type in the little looking glass on our YouTube channel, Medical Coding Cert, type in 99591, and I think you're going to find a video or two on that, and critical care probably explained out a little bit better. And if you're in our club, feel free to ask in there, and I can also find some more information for you on that, because that is one that gets very confusing, so it needs additional training on it. And I think that's it, guys. So, no. Yep, that's it. All right. Thank you, guys, and I'll see you next time.
Have a good weekend, everybody, and keep on learning.
Yay, keep on learning.